Hello, everyone. Reid and I are so happy to be co-moderating this panel on psychedelics and eating disorders. We have an incredible group with us today, a really wonderful mix of seasoned eating disorder clinician and researchers, as well as experienced psychedelic researchers coming together to reflect on and talk about the potential, the issues, the questions that we have and that others might have surrounding the application of psychedelic medicine in the context of eating disorders. To get started, we'd love to invite each member of the panel to both introduce themselves, but also to tell us about the eating disorder related research that you are doing at your site, and anything else you'd like to share with us at this time. And so I can get us started. My name is Adele Lafrance, and I'm a psychologist from Canada, now living in the US. I work for an organization called Novamind, involved in psychedelic research. And through that affiliation and other affiliations, I'm involved in 3 different eating disorder related studies, one on one related to FCAP, emotion focused ketamine assisted psychotherapy for anorexia nervosa. I'm also the clinical investigator for the MDMA assisted psychotherapy for eating disorders with MAPS, and a collaborator with Meg and others who will tell you more about the study on the use of psilocybin for anorexia nervosa. Reid, do you want to go next?
Sure. Thanks, Adele. It's exciting to be here and talk about this topic that's near and dear to all of us. I'm a psychiatrist based in Utah with a special interest and focus on eating disorders. I'm the medical director at Center for Change, a treatment program out here for eating disorders. And last year I started a clinic called Cedar Psychiatry to help bring innovative evidence-based treatment modalities to individuals, especially those with eating disorders where traditional treatments may not have done enough, and they may need some new options. So we have 4 locations now and really focus on ketamine-assisted psychotherapy. Our parent company is now called Novamind, and I've just joined them as Chief Medical Officer. And as far as research studies go, my primary passion is in research and clinical work. And I've been working with ketamine for 10 years. Did my first ketamine study in 2011. Currently I'm working on an emotion-focused ketamine-assisted psychotherapy study with Adele for anorexia. And I'm the coordinating investigator for the MAPS MDMA-assisted psychotherapy study for anorexia and binge eating disorder.
Thank you, Reid. Meg, would you like to go next?
Yeah, hi everyone. My name's Meg Spriggs. I'm a postdoctoral researcher at the Centre for Psychedelic Research at Imperial College London. So I work with Robin Carhart-Harris and Professor David Nutt. I'm one of the lead researchers on our upcoming trial looking at psilocybin-assisted psychotherapy for anorexia nervosa. So this is a small pilot study. We're looking for 20 volunteers with a diagnosis of anorexia nervosa to take part in 3 psilocybin dosing sessions over a 6-week period. We're looking first, it's a feasibility study. Is this a feasible and tolerable treatment for this population? Secondly, we're interested in efficacy, so is it an effective treatment? And finally, we're interested in sort of the underlying neuronal mechanisms. So we're including things like MRI and EEG. So if anybody's interested in finding more about it, the trial is up on clinical trials at the moment. We're hoping to start recruiting next year to start the trial early next year.
That's awesome. Thanks, Meg. Allan?
Yeah, hi everybody. I'm Allan Kaplan. I'm a psychiatrist, professor of psychiatry at the University of Toronto, and I've been working in the field of eating disorders for many decades, and am now very interested in the psychedelic space, and in collaboration with colleagues at Cedar Clinical Research, including Adele and Reid, and at Novamind, I really hope to develop a Toronto site for psychedelic research where we focus on the treatment of eating disorders with psychedelics, and can talk more about that during the discussion.
Thanks, Allan. Natalie?
Everybody, my name is Natalie Gukasian. I'm a psychiatrist and a postdoctoral research fellow at the Johns Hopkins Center for Psychedelic and Consciousness Research. And I'm working with Roland Griffiths and also Angela Guarda, who's our director of our eating disorders clinic program. Also with Colleen Spryer, who's a psychologist there. And we've had this pilot study of psilocybin running since late last year. Unfortunately, I've had to take a break due to COVID, but we're in the process of getting everything started back up at the moment. And we're investigating the effects of 2 doses of psilocybin in conjunction with motivational enhancement therapy, sort of motivational interviewing based approach, to see if there's to see if it's a safe treatment for anorexia nervosa, to see if it does have any effects on mood, motivation, and eating disorder symptoms, among other things. And it's very exciting to be here. I'm glad to be among other people who share interest in this and treating these populations. So I'm excited.
Thanks, Natalie. Walt?
Yeah, hi, I'm Walter Kaye. I'm a psychiatrist at University of California, San Diego. I'm director of the eating disorder program and professor of psychiatry there. Like Allan, I've been working in this field for a number of decades and done a lot of research in serotonergic metabolism and its role in eating behavior, anxiety, and inhibition. And clearly there's disturbances of serotonergic function in anorexia and other eating disorders. And the tools we've had, the medications we've had so far haven't been that effective. So, being able to look at new approaches is really very exciting. And, so we've been working with one of the companies in the field that, is offering to sponsor a study. We're not quite there yet, but we hope to get it started later this year. And I'm working with Sphanie Knatz, who's really the project director on this study, and I'll let Sphanie talk about it. So.
Hi, everyone. Thank you, Adele. It's great to be here. As Walt said, we work together. So I'm also at the University of California, San Diego, where we have a really large eating disorder clinic and research program, mostly focusing on neuroimaging research. I'm a clinical psychologist by training. I've spent my whole career, though don't have the privilege of saying multiple decades like Allan and Walt, in this field of eating disorders. And I'm really passionate about studying novel models of treatment that break through traditional models. The program that I direct at UCSD is novel, also in that we provide intensive treatment over the course of 5 days and involve supports and family members. But I'm really looking forward to this pilot trial that Walt and I are hoping to begin, as we said, at the end of this year. So much like Natalia and Meg, our trial is a small pilot study, really primarily focusing on treating individuals with anorexia and seeing if psilocybin is a safe and tolerable treatment. So we're first measuring that and how acceptable this treatment is, how easy it will be to recruit people. And secondarily, looking at kind of outcomes as well and efficacy, really focused on primary eating disorder symptoms. So typical eating disorder pathology like restriction and anorexia. We also have a very keen interest in looking at anxiety and how this medication might help with anxiety, and then how that sort of moderates eating disorder symptoms as well. So we hope to begin, we're not quite there yet, but we hope to begin recruitment sometime towards the latter end of this year. So.
Amazing. Thank you, everyone. I'll jump in with our first question. And I'd like to start with how these medicines work in the context of eating disorders. So based on our current understanding of the neurobiology of eating disorders and our understanding of the mechanisms of various psychedelics, what do we know about why they might be effective for eating disorders? Maybe I could ask Walt to start with that one if you have some thoughts.
Sure. Yeah, let me talk about psilocybin, which is, probably a little bit maybe more kind of theoretical, evidence here in terms of why it may work. Um, so what are the disturbances that people have, for example, with anorexia and bulimia in terms of serotonergic activity? It really kind of depends on kind of what state of illness you look at, but there are, if you can measure serotonergic levels in the brain indirectly by measuring concentrations in spinal fluid, and, the studies have shown that there's abnormal concentrations, but more interesting than that is there's a lot of serotonin receptors. It's not like turning a light switch. You release some serotonin and all of a sudden the receptors all turn on. It's not like that. Some receptors are kind of activating, some are inhibitory. And the two that have been looked at the most are serotonin 1A and serotonin 2A receptors. And that is actually pretty consistent. There have been replicated studies that actually show that serotonergic 1A actually seems to be increased activity in the brain, and serotonergic receptor 2A is decreased. Now, why that's interesting is that these receptors actually seem to have opposite actions. The 1A receptor is inhibitory, the 2A receptor is facilitatory. And to some extent, one of the places they sit in the brain is called pyramidal cells, and these are cells that actually drop down through the cortex from one layer to the other, particularly in the frontal lobes. And what they probably do is they probably connect these, very simplistically, they connect the brain together and they process the flow of information. And so, these may actually be very important in terms of kind of inhibiting and facilitating that information. And, people with anorexia and to some extent bulimia are kind of overly inhibited. And, you could theoretically think maybe one of the reasons for that is because of increased influence of the 1A receptor. And, and psilocybin works on these receptors, I think particularly on the 2A. And so you may actually change the flow of information, flowing through the brain. It's like having a lot of phone wires going into a switchboard, and you have to kind of sequence things and organize them very, very kind of finely to make the whole system work. And this may actually kind of turn that system up and flow more information through. If you get too much information, you get delusional hallucinations. Maybe just ramping it up a little bit, might help to kind of reduce some of the inhibition that people feel. So this is based on some of the neuroscience data out there, but a lot of it's kind of hypothetical. I will say that years ago we did a study with MCPP, which is kind of another serotonergic drug. That's kind of a dirty drug. It's got a lot of different actions. But we actually, and people with anorexia actually seem to kind of improve their mood, as I recall, as usually it made other classes of people more anxious. But I remember having one girl that got this who was a very anxious, inhibited, entrenched anorexic, and she started laughing. And she holds out her arm like this and goes like, "Why do I think I'm so fat? I look fine," And she goes, "I've never felt so good in my life." This is a girl that, never laughed, never felt good. And that lasted for about an hour or two, and then it went away, as the drug wore off. And I just kind of looked at that one like, there's something really important going on here that we really need to kind of understand, and maybe some drugs that act on this system might be helpful.
Thank you, Walt. Go ahead, Sphanie.
I was just going to add too, because I think this is of interest to many of us here. Walt saw that finding, and I think most of us are kind of doing a combination of supportive psychotherapy surrounding the dosing session, and how we can take sort of insights like that and really develop them in integration sessions and kind of prepare people for how they want to make use of these and how they can enact changes that are related. So, it's interesting to hear that finding, and kind of curious about how the package that we're using here, which includes both psychotherapy and the administration of the drug, might help us kind of, take that finding a bit, or those insights, and have people apply them in their lives in other ways.
Yeah, if I could just expand a little bit on what Walt said, and Walt's done the seminal research in this area. But at a phenotypic level, let's take anorexia nervosa. There are three core disturbances that we have to deal with as clinicians. The first is cognition. So people with anorexia have abnormal cognition, and they have abnormal cognition years before they ever fall ill with anorexia, especially in terms of executive functioning. They have a disturbance of affect, both in the regulation of affect and the recognition of internal affective states, which also seems to be faulty. And anorexia is a disturbance of motility as well. Anybody who's tried to treat an anorexic, you often find yourself chasing her down the street because she can't sit still. And some of my more chronic patients spend their entire day following the streetcar tracks in Toronto. One of them was tragically run over by a streetcar. These are prominent phenotypical manifestations of the illness. One could also speak a little bit about impulsivity, especially in bulimia. But my understanding of how a substance like psilocybin works is it through the default mode network by increasing brain plasticity, and that could lead to new forms of neural circuitry and communication across brain sections, brain areas that aren't normally there. And this could alleviate, and there's some evidence for this in some of the clinical reports, it could alleviate some of these core disturbances that I just spoke about. So remains responsibility of all of us in this field to conduct rigorous scientific studies to be able to demonstrate that such an effect occurs. And that's the challenge that I think we all face.
Oh, thank you. Fascinating topic. And I'll just add a couple thoughts on MDMA, because that study is moving full speed ahead for both anorexia and binge eating disorder. And MDMA, the way I like to think of it working anyway, is it dampens this intolerable negative emotional state that keeps us from going deep and moving towards the work. So it gives us better ability to process emotions, better cognitive control, enhances trust between the individual and their treatment team, their caregivers, breaks down barriers towards recovery, and produces this more kind of loved up, fear-reduced, emotionally engaged state. And because in things, whether it's anorexia or binge eating disorder, we're often turning to some of these subconsciously to move away from those negative affective states. So, well, Adele, I'll pass it back to you for our next question if you'd like.
Yeah, of course. Thank you. So this question is for Natalie and for Meg, because both of you are working at centers where there is prior research that has happened with psychedelic substances with different clinical presentations. And I'm wondering if you could speak to us about what you've learned from those other studies that you think could be helpful for the field of eating disorders as we approach these new medicines, as we conduct or start to kind of get ready to conduct some of these studies. And so, Meg, do you want to go first?
Yeah, sure. So anyone who's kind of followed what research has been going on at the Center for Psychedelic Research here will know that we focused previously on depression. And I think there are some key sort of similarities, but also some key differences between depression and eating disorders. And for me, sort of watching these depression trials, there were, I guess, amongst many things, there were two things that kind of really jumped out to me as might be really important in terms of eating disorders. The first of those is the ability for psilocybin to help people to change their perspectives. So one of the things we saw a lot in the depression trials was people felt like they were sort of breaking free of the shackles of very restrictive sort of mental thought patterns and rigid thought patterns. And it allowed them to kind of see their depression in a new light. And anorexia is a condition that is really sort of characterized by that very rigid thinking pattern. And we hope that, you know, with psilocybin, we can help to shift perspectives and move towards recovery. And a second part of it that I think is really important, and that we've already kind of touched on, Sphanie already kind of touched on a little bit, is the role of compassion. So I guess we talk about these trials like they're drug trials, but really not drug trials. They're psilocybin assisted psychotherapy trials, and a key component of that is love and compassion. And eating disorders are not kind. Anorexia is not kind, and a lot of the treatments have become very medicalized for obvious reasons. The most important thing is maintaining sort of physical stability, but along with that, there's another component to it. And I guess what I see psilocybin doing, and a lot of these medicines, is placing the individual, the client, back in the driver's seat. And what we can do around that using psilocybin and the therapy is to help to support them to shift the gears and move towards that recovery. So these were both kind of insights that we got from our depression trial that I can see would have huge impact here.
I love that you talked about love. It's one of my most recent obsessions, you know, in thinking about psychedelic research, because spirituality has come out as a really strong predictor of outcome. And I have a feeling that love will too, that we just need to kind of do a little bit more work to figure out how to measure it, how to conceptualize it, and then hopefully bring it into not just the psychedelic treatment, but more the conventional treatment way, in a way that feels comfortable for people. So that's amazing. Natalie, do you have anything to add in terms of what Johns Hopkins, what your colleagues have learned from all the amazing work you've done so far? And do you have any preliminary information about how things have been going so far with your study? I think maybe you've enrolled 1 or 2 patients, but yeah, anything to share from that regard?
Yeah, sure. So in terms of just what prior research has taught us and why we think psilocybin might be an effective treatment modality for anorexia, right? So in the early 2000s through now, the center had focused on work primarily in healthy populations, and then later moved to folks who were struggling with depression, anxiety, and also like terminal cancer, and then later just to major depressive disorder. And from some of that earlier work, in addition to what Meg highlighted, right? So they found that just a couple of doses of psilocybin in conjunction with the supportive therapy that's provided can, in many cases, produce pretty remarkable changes in, for example, temperament. So even in something like personality, which we normally think of as fixed, in healthy people, they were able to show that, you know, months later, the level of openness that somebody has, as measured by a personality inventory, that's can actually go up, which is pretty unusual. And not many pharmacotherapies have been shown to produce changes like that. I know that psychotherapy has on its own, but to produce a significant change like that after just a couple of doses is pretty remarkable. In addition to that, from a lot of the studies, they found that long-term, from just a couple of doses, there were pretty significant self-rated changes in like positive, healthy types of behaviors that people experience. And this was not because, you know, we told them to do these things. These, in many cases, happen just spontaneously. And lastly, from what I've observed, so I was also, I worked on some of the depression studies that had been going on recently or still ongoing. So I'm part of the USONA multi-site study that's happening in Hopkins too. And one thing I've noticed just clinically is that in a lot of cases, it can be, psilocybin can be a very powerful tool for enhancing mindfulness skills, which can be really important for people with eating disorders to allow them to get some space between themselves and the behaviors, which can often be really tightly wrapped up together as illness, when in cases where illness is really severe. And so those are some reasons that we thought that it might be helpful in anorexia. And obviously, there are pretty significant differences between those healthy populations and depressed populations and people with anorexia. And I think the main one is compromised nutritional status in a lot of these folks. And we're still really trying to figure out what what role that has in a person's sensitivity to psilocybin, their ability to gain any benefit from it. Another difference is that unlike depression, anxiety conditions where people very obviously want to get as far away from those things as possible, in anorexia, there's obviously a lot of ego synchronicity between their illness and themselves, right? In many cases, they're ambivalent about wanting to change. You know, they can, in some cases, see plenty of reasons, their families are giving them plenty of reasons they ought to, but they have a really hard time of letting go of those things. So that's like another key difference, I think, that is really important to take into account, especially when developing the therapies that go around the psilocybin. And so you're right, we're on our way. We've launched our study. We've enrolled a handful of people, and unfortunately we have to put everything on pause, as you know, due to COVID. But we did get a couple people through the intervention early on. And I think that the thing to say there is it's still kind of way too soon to sort of make any kind of conclusion about what we can expect from this kind of treatment. You know, there's not really a pattern that we can ascertain about what kinds of people are more likely to respond, what sorts of responses we can expect, when we would expect those changes to happen, right? Because also, unlike depression and anxiety, eating disorders also require a lot of behavioral changes that have to be maintained over a long period of time to really show substantive improvement, especially with like, refeeding and getting sort of resetting your nutritional status to something that's healthier. So it's a little bit too soon to say. In terms of safety, you know, so far we haven't run into a ton of issues. And in terms of, you know, feasibility or how acceptable it is to people, I think one interesting thing that was sort of alluded to earlier was the fact that, I think Allan brought this up, right, that people, it's a disorder of motility. And one big challenge that people have run into is just being able to deal with the fact that they have to lie still just for the entire day. In some cases, that's more challenging than in others for certain people. You know, some people are more focused on the exercise aspects of their behavior, but that's sort of something that we've had to work with in the preparation and integration, which wasn't really the case in other studies.
Thanks, Natalie. Yeah. And speaking with some people both in the eating disorder world and the psychedelic world, one of the messages that has come up a couple of times has been like, let's be optimistic, but cautiously optimistic, because it may not be that we're going to see these massive results like we've seen in the smoking cessation trials or in the MDMA for PTSD trials. And so, Walt, I'm just wondering, what are your thoughts about the level of optimism or even what you've learned from your decades in the field and that we could apply as we move forward in this direction?
Yeah, I'm certainly cautious about this. I mean, these are pretty powerful drugs, and you know, can have, you know, people can have kind of good trips and bad trips, and you know, it's a little bit hard to know whether. I'd be very curious to Natalie's experiences so far, whether, you know, she's seen kind of people have positive mood responses or negative kind of responses to taking these kind of drugs. It's and also kind of how hard is it to actually get people with anorexia to comply with, you know, this kind of study. And so, but you know, I think that you're always very limited about, you know, what is safe to give human beings and what the FDA allows you to give. And, you know, clearly these are drugs that we can try out now. So it's, you know, I certainly have some hope and optimism that at least for some people have beneficial effects.
So I can respond to that, Walt. So there's been kind of a mix, you know, some people certainly have a really challenging dysphoric sorts of experiences. Yeah. But importantly, from the prior work with psilocybin that happened at our center, you know, we kind of learned that, yeah, these are common in everybody. Something like a quarter to a third of people will have a significant dysphoric reaction during the session. However, that having had that reaction or that challenging experience, as we call it, is not necessarily correlated with poor outcomes. So in many cases, even though they do go through this really intense and what might be objectively viewed as like a negative experience, often there's it results in positive changes afterwards. You know, it might be, you might think of it as like sort of living through an ordeal, perhaps, because they always come out the other end, they're still in one piece, and we have plenty to talk about in the integration.
Yeah.
Yeah. Can I just add to that? Just building on what you're saying, Natalie, I think one of the things that we've focused on a lot lately is this idea of emotional breakthroughs. When you have those big challenging experiences, coming through the other end of that is actually, can be a huge part of that experience. And the experience does ebb and flow for everyone. But sort of preparing people beforehand to face those challenges can really be a huge part of the therapeutic outcomes, I think.
I think the interesting thing is that you really can't ever predict who's going to have that challenging experience. The folks who I've fully expected to have a very hard time in our study and in other studies often had a wonderful euphoric experience, and vice versa, where the people I expected to just breeze right through it had a very, very hard time. So that's I think it's a challenge across the board with working with these substances. And so, preparing everybody is usually a reasonable thing to do, just because you never know.
Thanks, everyone.
Fascinating. Yeah, we use the emotional breakthrough inventory routinely, Meg, in clinical practice and in studies. And based on the psilocybin research you're talking about and are working on, combining the mystical experience questionnaire, for example, with the emotional breakthrough inventory, under the idea that if you can face that difficulty and make it through to the other side, which everyone does, then that's where the lasting benefits might lie. So excited to see how the work in eating disorders in particular plays out. Well, let's talk about family involvement for a moment. Many of us operate under the belief that caregivers and families are some of the best allies for recovery. And in fact, there's a nonprofit well known to us called Feast. I believe Walt is on their advisory panel, which stands for Families Empowered and Supporting Treatment for Eating Disorders. So my question is, what does caregiver involvement look like? What might it look like with psychedelic therapy? And maybe we can start with Sphanie for that one.
I think that's such an amazing question for all of us to be thinking about, because, despite the fact that we'll be working with the people who enroll in our study and maybe eventually this treatment for, kind of a brief window of time, at the end of the day, all of us, including people with anorexia, go home to either live or have close relationships with people in their lives. And we think that that's, kind of a fundamental thing. In fact, so far, the research or studies have shown, particularly in younger populations of people with anorexia, that family-based treatment is the treatment type that has the most evidence and that works the best. And that has been more readily been applied to adults more recently with anorexia. So, I think the question of how to involve supports and caregivers, both to prepare them for what to expect from this experience, and then I think post and sort of a family mediated version of integration. And it won't be the same, they don't have the role of the therapist, but how can family members and supports continuously be involved and making sure that the insights and, breakthroughs that people have are continuously realized in their lives. So I love the question. I think it deserves a lot more thinking about how we can kind of make this model, embed it more in a system, which again is a question that has come up a lot for this particular population in eating disorders, because individual treatments have been quite limited in their in how people respond to them. So,
for those of us who deal with the adult population, it may force us to rethink involvement of family, because as you alluded to, the evidence supports family involvement for young patients, young people, mostly below the age of 16, and not necessarily for adults. And the traditional approach is to facilitate symptom separation from the adult patient, to facilitate separation, individuation, and getting on with their lives. And not infrequently, it appears that the family at times interferes with that process. So I'd be very interested in how we would, or one would approach in a family involvement in, let's say, the kind of patient I see who's had anorexia for 20 years and is 45.
Mm-hmm.
And what is the role of the family in a person like that?
Yeah. At our clinic, we are working on adapting kind of family-based models to young adult and adult populations, and even just starting with a paradigm shift, which is, as opposed to starting treatment with the fundamental assumption that people show up alone, you know, upon people coming in asking who's a support person, and maybe it's not a family member, family of choice, right? And someone who's been ill for 20 years, they might not have a parent or, you know, a spouse to fall on, but who is a support person that you can kind of nominate to be involved in your treatment. And it doesn't have to be at the same level that kind of a traditional family member would. But I think things like even education around what to expect, you know, and how to facilitate kind of continued change, support groups like that for family members. And this tends to be, I think, Reid, you mentioned FEAST. For whatever reason, eating disorders tends to be a field in which there is a lot of grassroots advocacy in families. This is tends to be a population of people where families really want to be involved. So, you know, I think the idea of capitalizing on that is important.
Yeah, and I can share a little bit about the ways that Reid and I have been incorporating family involvement in our work. So if we look at the FCAP protocol that we're running right now, actually, of the 3 participants that we're working with, 2 of them are brought in their spouse as their support person. One of them brought in their parent, and we have them join for the introductory session so that they can understand the model, understand our focus, and particularly the emotion focus part, because that's going to create some newness in the home in terms of, like, we're going to be encouraging them to have emotion focused conversations and so on and so forth. And so that happens, which we have found to be really helpful. And then while the identified patient, let's say, is going through the protocol in terms of the ketamine and the post-ketamine psychotherapeutic integration, their study partner, their family member, their loved one is receiving 2 sessions of coaching around supporting their loved one with emotion processing. So they get 2 emotion coaching sessions with an EFFT therapist, and they're also invited to participate during the dosing sessions. And those decisions are made by the individual who's going through the treatment. So far we've had a mix. One person has chosen to have their caregiver present for the dosing session and for the integration afterwards. One person has chosen to do that piece on their own. Another chose a hybrid of that model. And when we ask them, like, what is it like to have your support person involved, every single one of them so far have said that it has been a very positive experience, and it's actually brought them closer together. It's improved the communication styles in the home, and the caregivers who've received the coaching, they have said that it's been a relief, because sometimes they do and say things that aren't helpful, but it's not because they're, you know, unhelpful people. They just don't know what else to say. They're literally stuck. And so they're really appreciative of the support and the skills so that they can have a better idea of what might work. And we actually are going to be using a really similar protocol for the MDMA assisted psychotherapy project, where the caregiver is present for one of the prep sessions, and then they get their own separate prep session so that we can talk about any of their anxieties or concerns and start to teach them some support strategies that could be useful. And after every dosing session, there's the option of a dyadic integration session. So we are so thrilled that MAPS was open to doing that. It does increase the cost. It does require more specialized training on behalf of the therapists. But if we're going to follow the amazing movement in eating disorders where caregivers are seen as vital, I think that it's really important to do what we can to translate that into this field as well.
Right. I was going to add too that, like, caregiver burnout is it's so high, in particular with anorexia. And so to kind of intervene on that level is in and of itself such a powerful modality. So.
Yeah, everyone's suffering when there's an eating disorder in the family. Like, you just can't get away from it. It's such a difficult disease, especially when it's chronic. And so yeah, I think we're just really excited about kind of keep thinking about it. We don't have all the answers because we need to kind of be respectful of individual processes and family processes, and it's complicated, but I think it's worth it. So we could have another whole panel about this later.
Amazing.
All right. So thoughts on how to integrate psychedelic assisted psychotherapies within conventional treatment programs. And so, Allan, I mean, you have been in the field for decades. We'd love to hear from you in terms of your ideas, your cautions, in terms of how we can blend these approaches to take advantage of the best of what both can offer.
Yeah, I mean, I don't need to tell this group how difficult treatment is with people with entrenched anorexia nervosa. So again, if you're talking about the severe and enduring group, which many of us end up having to deal with because nobody else wants to and nobody else knows what to do. So I mean, the first thing is obvious. There are no evidence-based treatments, certainly no evidence-based medications, no approved drug for anorexia nervosa. It's the only psychiatric illness that does not have an approved drug. And sure, there are interesting findings in various trials. I was part of the olanzapine study. For select groups of people, it seemed to help. It certainly was not a magic bullet by any means. Just even getting people with anorexia to take medication is a challenge and requires an investment of time and energy in the therapeutic relationship. It is different than dealing with someone who wants to get better. So the treatment tends to be complicated, especially with underweight people, as Adele, you alluded to. It usually involves some kind of external control, whether it's a residential setting or a day hospital, sometimes an in-hospital inpatient treatment, and how one would integrate, let's say, a psychedelic intervention in the midst of a externally controlled environment. It kind of gives me a headache when I think about it, because I'm not sure one could do it. I wouldn't start with the hardest. I try to create a grid of what's most conceivably easy as opposed to what's the hardest. And a lot of these treatment programs have groups. So how do you integrate somebody on a psychedelic in a group context? I mean, I don't know how you do that. I don't know if anybody's had experience with that.
Actually, you're just making me think. Reid, can you talk about how you integrated ketamine in the context of the residential treatment program at Center for Change?
Sure, yeah. This was back in 2018 that we started a pilot program using group-based ketamine-assisted psychotherapy for eating disorders, where four individuals who were residential clients would go through that process together. And it was so powerful, both the group setting and having this new modality that, may not be FDA approved for this purpose and may not be well studied for this purpose yet, but it has a lot of evidence around it for as a rapid antidepressant and a lot of hope. And so that's the biggest thing I took away from that is psychedelic medicine is a source of hope. Yeah, there are potential powerful promises. There are also pitfalls. It's not for everyone, but I think that's one way where we were able to, I think, run several dozen people through that program and had some beautiful outcomes that we're writing up right now.
Thank you. Meg, do you have any thoughts or comments about what we might need to think about when we're kind of planning these studies, or even thinking about when they're legal and they can be used in the context of conventional eating disorder programs?
Yeah, and I mean, I think I just wanted to pick up on something that Allan said, that buzzword, that magic bullet, that I think, a lot of people, there's this idea, this reset button idea of psychedelics, that people come in and they kind of they might come in with this idea that psychedelics are going to be the answer and they're going to walk out a different person. And what we know from other studies is you know, the psychedelic, the dosing session is only one part of it. And around that is that preparation, and that integration is so important. And I prefer to kind of view it as psychedelics open the door, but there's still, you know, the individual still has to walk through that door. And with eating disorders, I think that's extra important. And I mean, one thing that we don't know yet, because the research hasn't been done, is you know, if this was to roll out with any condition, we don't know sort of how often you have to have another dosing session, and all of those questions still remain to be answered. In our, you know, in our depression trials, it was up to 6 months people were getting antidepressant effects, but then, you know, the depression started to creep back in. So if this was a large scale therapy, would you then have to go on and treat again, have another dosing session at 6 months? We just don't know. And with eating disorders, I think this is particularly important, because those, you know, it's the recovery process involves you know, asking someone to sit through some really uncomfortable emotions and some uncomfortable feelings and sit with that you know, consistently for a very long period of time. You know, with that weight recovery process, it's long and it can be very, very uncomfortable. So how can we sort of, you know, create that integration so that has a lasting effect through that process? I think these are really good questions, and I don't have an answer. I don't think any of us do yet, but hopefully we'll work towards that. Yeah.
So just if I could jump in here. So I think one thing we still have to figure out also is what the optimal situation is in which somebody should undergo this treatment, right? And so right now, one question that we have is, how much does their nutritional status really impact their ability to sort of even feel any of the effects of the psilocybin, right? And so I can potentially see, you know, one day, for example, we know that if people are very severely ill to the point where they require hospitalization or residential treatment, often even though, you know, treatment itself can be really challenging, people's anxiety goes down, their mood improves once they're refed a little bit and they gain a little bit of weight and they're a bit closer to a normal BMI. And so it's possible that this kind of treatment might really be best for people who are, you know, weight restored or close to weight restored, might have a healthier BMI. And in any case, it certainly would be safer to offer this kind of treatment after they're sort of in a healthier place physically. You know, in our study, we've had a lot of people reach out to us, you know, who are really desperate to help their family member who is just, you know, very, very, very ill. And we just unfortunately have to say, you know, medically, it's not safe for us to do this for this person. And so in the future, I could potentially see it as being something that's offered, you know, for example, the tail end of a residential or an inpatient treatment, maybe in conjunction with members of their team who they've already been working with and who they've established rapport with. That's not the model that we're using in our study currently. But these are just sorts of questions that have come up around what might be an optimal and safe way to provide this kind of treatment in the future.
But let's not minimize the importance of that, because you can get people to gain weight if you put them in a certain environment, especially if the patient experiences it as somewhat noxious. But we all know the high relapse rate that goes along with weight restoration. You could spend 4 months in a hospital and gain X number of pounds, and the patient will shed that weight in a matter of a few weeks. So, you know, even if we just look at psychedelics as a kind of relapse prevention strategy, it could have dramatic import and effects and prevent the recidivism that we all have to experience and the patient has to go through and the family. So I understand completely the importance of getting people medically stable, but keeping them well is actually a bigger challenge.
Yeah, so true. I'll throw out one more question for us before we start to wind down. Is what would help advance this field? And what are some of the ways that everyone, clinicians, clients, caregivers, can come together and make progress in this worthy cause, and also to help raise awareness, reduce stigma? Maybe we could start with Sphanie for that one.
Such a great question. You know, I think we're here, many of us, because we are wanting to investigate and explore novel paradigms. And I think what has been true for the field of eating disorders, and actually a larger problem in mental health, is this kind of, the paradigms that we use might be limited, right? And so even coming into this space and applying a new paradigm with the combination of, you know, a psychedelic drug and psychotherapy, that in and of itself, I think, holds promise, that we're kind of not, you know, applying a different model of outpatient therapy in the same setting. So I'm really interested in, again, novel paradigms. And I think that can really, that's something that holds great promise. I think also being in a group like we are, where we're all keenly interested and, you know, applying scientific minds to really just seeing what happens and investigating what happens versus kind of holding on to something that we think is going to work. And I think that's where we're at in this eating disorder space, is to kind of test safety, tolerability, acceptability, and how people are responding with efficacy measures, and so that we can learn more and then kind of develop our treatments from there. So yeah, I think that novel paradigms, including this one with you know, psychedelic drugs, is what holds great promise for this field, trying new things. So.
You alluded to this, Sphanie, but most of the other interventions that we have to deal with in psychiatry don't have such negative connotations as does this group of substances, medications, and that goes back, as we all know, many, many decades. And so we have to repair the damage that's been done, just in terms of the way in which these substances have been viewed, not just by regulatory authorities, but by the general public. And so that's a challenge that I think we all have to deal with. And we do that, I think, by establishing evidence-based proof of some degree of efficacy, but also education, that we know a lot more about how these substances may work. We have better tools to assess that, whether we use neuroimaging or other means to do that. I think that holds promise, that we can address the stigma and the bad rap that these substances have in order to advance the field. And that's important because at the end of the day, this is going to require money. And currently, funding agencies are not likely to fund these kinds of studies at this point. That's at least what I would have experienced and hear about. It's mostly private philanthropy that's funding a lot of these trials right now. So that's a challenge I think we have to tackle along as we begin this journey.
Yeah, I think as excited as we all are about this as being a potentially really, really incredibly powerful treatment modality, I think it's important to point out that we still don't know, right? A lot of the studies that we're basing our excitement on are very small. They're in other populations, and so we're just getting started. And I echo that it's important to raise awareness as much as we can in order to be able to get the funding and resources that we need to actually answer the question about whether this is really going to be a treatment that we can use to help people with anorexia nervosa and other eating disorders.
All right, so let's move on to closing thoughts. And so we would love to invite each of you to reflect on the discussion that we've had so far and share with us any final thoughts, questions, concerns before we wrap up today. And so Meg, we'd love to hear from you first.
Yeah, so first I'll just say it's been really amazing to be part of this panel. It's a humbling experience to be part of this movement, really. And I think we've touched on some super important topics today. I think just building off what we've just talked about the stigma around psychedelics, I think what we're also doing here is helping to shift the stigma around eating disorders as well, which I think is equally important. There's a big movement at the moment towards a better understanding of mental health, but I feel like eating disorders somewhat fall behind in that that understanding isn't out there, and particularly at the moment during the current global crisis. I know that eating disorder rates are on the rise. I saw an article today that was just saying that Scotland calls to the eating disorder helplines have doubled over the last couple of months, and so just raising awareness in both of these fields is yeah, really important, and thank you to everyone here for the effort that we're all putting into this. Yeah, and I'm excited to see what happens.
Thanks, Meg. Sphanie?
Yeah, everything that Meg said. And I feel it's so exciting to be part of this group. And mostly I just, yeah, I have the investigator hat on to see what we find, right? What findings come to us as we kind of continue through these studies, because we don't know. Something that came to mind for me, since I'm a therapist on a depression trial with psilocybin, I've had 2 cases now of people not eating disordered, but with significant body image issues, who came in and reported during integration sessions that they felt dramatic improvement in body image problems. And so as a field, we've done quite a poor job in developing treatments for body image. And that's one of the primary complaints that people come to us about. And so don't know, but, you know, just looking forward to seeing, you know, what is the mechanism, if this works, how well it works. And again, what are some of the mechanisms of change here? Because we don't know that either. So.
Right. Yeah. Thank you. Natalie.
Yeah. Also feeling really grateful to be here today and to sort of be a part of this, and also be able to just have the opportunity to do this kind of work, especially because I never thought I would be able to do it like this early in my career. So that's like pretty stinking cool. And I have a lot of thoughts about this, obviously, but I think one thing as a psychiatrist, having worked on like a specialized eating disorder unit and working with patients who are really, really ill, you know, who come to us sort of in the middle of in crisis, basically, and where, you know, the treatment of choice is to, as Allan sort of said, all these external sorts of things that we put upon them, where we say, okay, you know, I know you really don't want to eat, but here is like a 3,000 calorie meal plan for every single day, which is like the last possible thing that people want to be doing. Meanwhile, they're telling us, you know, like, you don't understand like what's really going on. It's more complicated than that. It has to do with this and that, and this element of like my past and who I am as a person. And so I think it's like one really stark difference between conventional sorts of treatments and this kind of treatment has just been the fact that we do get to focus a lot on those other aspects of what's central to a person's sense of self. Not that can't come up in other kinds of just psychotherapy treatments, but it's really just a core part of things. And so that's been just a really awesome thing to sort of be a part of and to see in action.
Thanks, Natalie. Allan?
Yeah, I think first and foremost, we all owe thanks to Adele and to Reid for bringing us together. And this, to me, is the only way we're going to get this done. So it reminds me of the early 90s, and it was Walt, myself, and 3 or 4 other investigators who were trying to do genetics, and we couldn't do it on our own. It was just impossible. We didn't have the numbers. Anorexia, we're talking about specifically anorexia, but it's true for, to some extent, to bulimia as well. We need a large group of investigators who will work together as a collaborative, and that's the only way I think we're going to get the adequate numbers into these trials to be able to prove efficacy. So I commend you for taking the lead on this, and I just think we need to bring, as you said, Adele, whoever is involved in this together so that we can form a consortium and tackle these challenging problems together. The sum is much greater than the individual parts, for sure.
Thanks, Allan. I've been watching your work for years and years, and so it's just so wonderful to have you on board and in a leadership position. So that's wonderful. Reid?
Sure. Oh, this has been great. And as I just mentioned, psychedelic medicine for me is a source of hope. And anorexia has no FDA-approved meds. Bulimia and binge eating disorder have one. But we have binge eating disorder added as an indication for the upcoming MDMA study. With Adele and Allan at Novamind, we're working on a proposal of psilocybin for bulimia. And Adele and I have been working with ayahuasca in jurisdictions where it's legal, where we can, including with individuals with eating disorders and their families. So it's happening. Psychedelic therapeutics are not only coming, but they're here. Ketamine-assisted psychotherapy is here. And I used to get asked, how in the world could you give ketamine in your clinic? And I would just think, how can you not? How can we not reach for new paradigms of helping the individuals we care so much about, and with the right amount of caution and collaboration? So I'm very hopeful about the path forward and excited to be any part of it.
Thanks, Reid. And I guess I'll say that when I first submitted my a protocol for IRB review at the university where I was working at, review board, ethics review board, one of my colleagues was on the review board, and he came to my office, and it was, in the evening, I was getting ready to go, and he knocked on my door and he said, "Do you know what you're doing?" And he meant it to caution me. He said, "You're at risk of compromising all of the work you've done so far." And I'd spent years working on the development of emotion-focused family therapy. And he said, if the timing isn't right, this work is going to really could negatively impact the previous work. And I actually did experience some of those challenges. But for anyone watching who's interested in this work, it's so different now. It's so different. And I think it's because we have demonstrated that we're not interested in putting the cart before the horse, that we are really dedicated to safety first and foremost, and also from hearing from all of the stakeholders, not just the patients and their families, but providers and other researchers from different fields. And so I think that it's going to be important for us to continue to do that, to have those collaborative conversations, to build communities, like Allan, you said, so that we can learn from each other. We can hear from people with lived experience, so that we don't end up working in silos. And so I'm so, so, so grateful to everyone on this call. I tried to find all the people who were working actively in the field. And then Reid and I were kind of thinking about, okay, what do we want to focus on? There's so much to say and do. And we are just so grateful to you all for having made the time, especially you, Meg, because we know that it's quite late where you are at home in the UK. And I guess I'll just add, that we talked a lot about anorexia nervosa today. And though binge eating and bulimia nervosa have treatments that are effective, I do want to advocate for us to include all of those eating disorder classifications, because on the whole, there are just too many people suffering with food and weight related disorders. So thank you everyone for your contribution. Reid and I, again, are so grateful. And I really, really hope that we can continue to have these kinds of conversations, whether they are public or offline, so that we can support each other, learn from each other as we move forward.
Thank you.